Hey everybody, Chad Madden here, and welcome to another episode of the Grow Your Practice podcast. Today we have I know I always say very special guest. This one happens to be one of my best friends, probably my best friend in PT. Pretty unique story. We're really going to get into this. Very much looking forward to it. But our guest today is physical therapist, DPT, practice owner, Dan Neff. Dan is here is originally from Quarryville, Pennsylvania, Lancaster County, Pennsylvania, about 45 minutes south of where I record from here. Dan's a great guy. I think you're going to love this episode. So welcome to the podcast here, Dan.
Thanks for the invite, Chad.
Awesome. So we grew up in Quarryville. What did you do after high school? I know you had a pretty storied wrestling career in high school and college. What did that look like? How did you eventually go from that to get it involved in physical therapy?
Yeah, that wrestling career was a long time ago, but yeah. So essentially I got hurt my sophomore year in high school, tore my meniscus, had surgery, went to PT. Kind of a lot of our stories, right? It was like, hey, this is a pretty cool field, like looks awesome. So got to compete at the Division I level, went in there with all the intensive purpose to get into physical therapy, and sat down with the coach, and he's like, you can't take that. Like, that's way too hard. Like, there's no way you can compete and take this schedule. So he completely changed my schedule. And, 4 years later, I had a good career and essentially had a crap degree. So, I went on at that point. I'm like, wrestling's going to be my career. I was trying to make a world team and an Olympic team, and went on. I went to George Mason after that, and got my master's degree, was coaching, and then got a job in Iowa, was coaching, trying to make a world team, and just it didn't happen for me. So at that point now I have 2 small children, and I need to go back to school and figure out what I'm going to do with my life. So I ended up moving back home, and essentially a few years, but then I essentially went back to DPT school.
Hey, podcast listeners, when we make assumptions about others, it's just not fair. In spite of that, I'm going to make an assumption about you. You have a growth mindset. You want to help more people, leave a bigger impact, build a better practice. Am I close? If I'm right, then I have a unique offer that I think you'll be interested in. But first, if you're a regular listener, you probably know that this is brought to you by Breakthrough, the leading platform for private practice growth. Breakthrough's mission is to help people in pain get back to normal, live healthier, and do it naturally. The best way to do this is by empowering private practice owners like you to grow your business through direct-to-consumer marketing. If you're a practice owner with a growth mindset, you'd benefit from a risk-free consultation with a Breakthrough growth expert. Go to getbreakthrough.com/podcast offer to take advantage of this unique opportunity. On that call, you'll learn the key principles of how practice owners are helping more people, creating a bigger impact, and building better businesses with Breakthrough systems. As an added bonus, the team at Breakthrough is giving a $50 Amazon gift card to any of the podcast listeners who attend this growth consultation. Sign up for your growth consultation and $50 gift card at getbreakthrough.com/podcast offer. Again, that's getbreakthrough.com/podcast offer.
Nice. And that is how we met. And when you were in DPT school at Lebanon Valley College, I remember, so I was invited in, I believe, by Mike Lear it was a 45 minute or 50-minute manual therapy demonstration. And I remember doing a supine thoracic thrust. I forget what her name was. I'm thinking Kristen, and I know that's not right. But there was a pretty significant cavitation. Half of the class, their jaws just their jaws just bounced off the desks. And I remember like looking, and you were standing right there, like trying to get every little detail of exactly what I was doing. And then ultimately you came for a 16-week clinical to our practice, our very young Madden PT at the time. How close am I to remembering that correctly? Because we're both a little bit more gray than we were then.
Yeah, that's pretty much how it went. I guess the old saying, you had me at crack. So as soon as I got it there, I was like, all right, I'm wherever this guy is, that's where I'm going.
Nice. So I know you were driving an hour plus one way to do that for the entire time. Shortly thereafter, another unique story is you basically had experience at a pop's practice, and that became your private practice overnight, right?
Yeah, pretty much.
Okay.
Yeah, so it was a situation where when I came back, I started working for a work hardening company and kind of doing like physiology type things. And anyway, it some things broke down. They sold, and essentially, I went out. I'm like, I gotta do something more significant. So I had a good friend who was a family doctor. So talked to them. We talked about starting a physical therapy practice. Started that practice, but then as I went through DPT school, I was like, like this isn't right. Like physicians and physical therapists should not have a financial relationship together. Because what was happening was we had a couple practitioners in a couple clinics that were essentially, I mean, they would get patients better, but they weren't putting their hands on the patients. They weren't doing any significant treatment with that patient. But yet we can, and they were getting maybe half the patients better. But yet we continue to funnel patients into them because it was a financial benefit. So at the end of when I finally finished DPT school, I basically said to the group, like, hey, like I can't be a part of this group anymore. Like I'm going to go out on my own. If you want to send patients to us, because we're doing some different things here with this manual therapy, then great. If not, I can't have this financial relationship anymore. So one of the practice owners went really well with, the other not so well, but yeah, that's how it rolled out.
And in the end, it all worked out, right?
It did.
Great. So what does, fast forward to today, what does your practice look like today, just for context?
So we have our main flagship in Quarryville, Pennsylvania. So that has 2 full-time teams and 1 part-time team. And then we have a branch practice that we started 2 years ago now in Willow Street, Pennsylvania, about 15 miles north of that. And that has 2 full teams. And we just purchased a 3rd building where we're going to have a practice in Oxford, Pennsylvania, as soon as the build out occurs.
Great. Yeah, I know just from being in the clinic, you're essentially the mayor of Quarryville, and everybody knows who you are, and you have a great reputation there. The other thing that I wanted to say, and I don't know if you remember this, but when we were at LVC doing the class, and you said, you had me at crack. I remember for your in-service, when you were a DPT student, you did an in-service on vestibular rehab, and the presentation was just so much more than I had ever actually been exposed to myself. Do you remember doing that at all?
I do. Yep.
Yeah, it was very thorough and legit. And I was like, oh, this guy's unique and different, and world class, going to put the time in. So a lot of different directions we go to here. We talked a little bit about private practice. I know, you're huge on manual therapy, with like full disclosure with, with breakthrough manual therapy, you're teaching manual therapy courses all over the country. Can you talk about that? Maybe throw in there, the vision of flipping the pyramid, your passion for private practice PT, and ultimately what we can do with musculoskeletal and neuromuscular health?
Sure. So, when we talk about having an autonomous practice, right? That's the vision that we have for physical therapy, and that's the goal of breakthrough manual therapy. We want to try to get out there and create a healthcare society where physical therapy is the first choice. And I know we hear that a lot, but we are the right practitioners. I get to spend a lot of time with MDs and DOs, and they do an amazing job at a lot of different things. But we are very, very good at musculoskeletal evaluation, and we're good at healing these type of injuries. But for us to be truly autonomous, we have to get patients better, and we have to get patients better on a consistent basis. We can't just have like a good clinic here and a good clinic there and have all this variety throughout our profession. We have to be able to put out a product that consistently allows patients to leave our facility and go out and scream our name, like, you have to go there. Like, I was at a bunch of different practitioners and no one fixed me, and I went there and my pain's gone. Like, that's where we need to get to change the public view so that we are the first providers. So that's the goal of essentially the manual therapy part of it, because we found this system that we do significantly change patients, like consistently placing our hands on the patient and going to a neurophysiological approach by treating the spine first. We've created this process, and I know we do it in Harrisburg at your facilities. We do it in Quarryville, where patients come and see us first because they know that they're going to get better every time that they come in. So with humbly saying that, we just want to try to share some of what we do and what we've learned in the system that we use with our colleagues, so we can kind of help physical therapy grow to that autonomous practice.
Great. And I know a personal conversation that you and I had just a week or two ago, you were talking about inguinal pain with suspected hip OA really having an L1 restriction. So can you talk through that, or even what you've seen work really well with like adhesive capsulitis, and how you think through the science behind helping those types of pathologies?
Yeah, so just trying to think outside the box. So you have your 55-year-old patient that comes in, right? They have inguinal pain, and we know just screening that patient out for hip OA. So you take that patient into hip flexion. They have full hip flexion. Right now they have a radiograph that says they have hip arthritis. So you take them into flexion, they have full flexion, right? No pain. You take them into internal rotation, they have full internal rotation. So you're like, oh, like, when we look at research, we're talking cluster tests. When someone has arthritic hip, what do we lose? We lose hip flexion and internal rotation grossly. So now you have a diagnosis of arthritis because they have a hip x-ray that's positive, but yet they have no arthritic components to your eval. It's basically benign. So what are you going to do with that patient? Like, you're going to strengthen their hip, or they have inguinal pain? Are you going to do transverse friction massage on their, tensor fasciae lata, their, hip flexor? Like, you're going to just roll their hip out? No, like, it's not coming from their hip. So when we look at the peripheral, nerve innervation of L1 and 2, the ilioinguinal and genitofemoral nerves, it's the inguinal region. So if you have a restriction in the upper part of the lumbar spine that's causing inflammation, fibrosis, irritation to the nerve, it's going to show up at the inguinal region in that patient. So flip that patient over first before you do anything else. Screen out their lumbar spine, treat any restrictions in that upper, lumbothoracic region flip them back over, retest them on something that hurts, and almost always those patients are better. So we are seeing that the more and more we go to the spine, the more and more we change these patients. So I could keep going on how that works, but
Well, that's great. You basically led to a result on the first visit, and that would be the type of patient who has failed other treatments, right?
yeah, I think because what ends up happening is the patient has inguinal pain, right? We tried stretching their hip out. We're just stretching an irritated tissue already. We tried rolling their hip out. Well, the source of the pain is not originating from that region.
Yeah, great. So completely understand. Now talk with, okay, so you see the patient on the first visit. I know one of the big knee-jerk reactions for many clinicians is, well, if everybody that I saw, I got better on the first visit, what are we doing? And I know in our clinic, we do the 3 phases of healing, where we go through that UPN or University of Pittsburgh model, where we're talking about reduction of inflammation and pain first, and then we talk about normalized or restoration of normal range of motion and other objective measures like strength, and then finally we're doing return to function. So I come in, I have I have hip pain, I'm feeling 75, 80% better after the first visit. What are the next steps of my rehab process? How do you think through that?
Yeah, I totally agree. I mean, there are a bunch of things that have to happen, right? The patient has to be pain-free or doing really well for at least a week. They can't come in for one visit and say, "Hey, I'm fixed, I'm pain-free," right? We want to see that. We want to see that extend. The restrictions have to be gone. So you have to have some objective way of saying, like, why am I like mobilizing this patient's spine, right? You just, all right, they have back pain, so are you just going to go and crack someone's back? Or no, like there has to be a reason why you're doing that. And that's one of the things that we try to push for through the restriction-based approaches. We don't mobilize healthy tissue. Like there has to be a restriction there. And if there's a restriction, there's a potential reason why that patient continues to have pain. So number 2, the restrictions have to be cleared or pretty much gone. You know, you have an 80-year-old person, you're not going to get all of their restrictions in their spine gone, right? But they're better overall. You know, they have to have their full strength returned. So all those neural structures and those neuromuscular connections have to be restored. They have to have full strength. And then they have to return to the functional tasks that they wanted to do when they first came in. You know, if they wanted to ride bike or get back to the gym lifting, like, hey, I want you to go out. You're doing really well. Take a week, go ride your bike, go back to the gym, do whatever you want to do. I'm going to see you in 7 days. If your restrictions are gone, your pelvis is square, you're feeling good. Hey, you're good to go then.
Love it. So manual therapy sounds like you're getting a huge lift in terms of reputation, marketing, your brand within the communities you're in, making a difference there. Ultimately flipping the pyramid in those areas, which is awesome. So
Chad,
yeah.
So in that thought process, just kind of throwing this out there. So yes, you know, you can get those patients better right away, but in the long term, that flips the pyramid, because essentially what you don't want to do is keep a patient for 20 visits that's better in 8 visits, right? Because what ends up, regardless of how busy your practice is, if it's slow, you know, or busy, because what ends up happening is that patient gets that thought process in their head. Oh my gosh, you know, I have to go back to physical therapy. That requires 20 visits, right? If we can get the thought process of get that patient in, get them better. Like, I wish I could tell you your pain's going to go away forever. It's not. Like I have back pain a couple times a year that I got to get the guys to work on. But if you can get them better and get them better consistently faster, they're going to come back to you every single time, because they know that they're going to get that result. And I think in turn, that builds our reputation in the community. It builds our reputation in the medical world, and we flip the pyramid.
Yeah, great.
This podcast is brought to you by Breakthrough, the leading platform for practice growth. Breakthrough has helped over 1,500 healthcare practice owners leave a bigger impact in their communities and grow a larger business. As the founder of Breakthrough, I've developed a library of educational resources on practice growth. These are based on my learnings from my own experience as a private practice owner, plus the experience working with thousands of other owners in the Breakthrough community. If you have a growth mindset and you're hungry for free resources to help you grow, check out Breakthrough's Resource Hub. Go to getbreakthrough.com/resources, where you'll find on-demand trainings, tools, templates, planning guides, and a host of other free resources. Again, you can find these at getbreakthrough.com/resources. If you're interested in getting direct support with your practice growth, you can request a free growth consultation at getbreakthrough.com/podcast offer.
I know you're doing some work in neuropathy right now. Can you talk about how you're thinking through that? So you're not only doing musculoskeletal, but you're also focused on helping people with neuropathy. What are you doing there?
Yeah, that's been pretty cool. So initially, Carl reached out to us and asked us if we could test one of the new neuropathy treatments on the market, the new fit. So essentially what happened was we tested the neuropathy funnel at our practice. So we needed neuropathy patients in there. And I was like blown away. I was like, we live in a pretty small town. Like there are literally 1,200 people in the borough limits. Now we have, sprawl that's going on all around us. But we had 31 people register the first time that we put the workshop out there. So essentially we brought those patients in. And what we wanted to do is we wanted to see what the combination effect was of doing manual therapy, going to that neural approach with these patients who had neuropathy, as well as combining it with the direct current of the new fit. So essentially we tested 2 different trials. We had 9 patients in each trial, and we found a significant change in 3/4 of the patients in both trials with a combination of the manual therapy hands-on spinal approach, as well as combining it with the new fit.
And this is primarily diabetic neuropathy?
So yeah, so some of it's diabetic neuropathy, some of it's just peripheral. I mean, we've had patients. We're doing EMGs in our clinic, so we've had patients that had just a sensory neuropathy. Some had a motor neuropathy. I had a patient that had chemotherapy-induced neuropathy, alcohol-induced neuropathy. Like, yeah, there's a bunch of different types of neuropathy.
Okay, fair enough. You're also doing, you've either completed or you're about to complete a fellowship in diagnostics.
Yep.
Yeah. What are you doing there?
Yeah, so that's been pretty cool. It's really interesting, the educational approach with diagnostics. We learn a lot of neurology in our physical therapy training, but what we overlook is the peripheral nerves, the peripheral nerve fields, and there's a lot of that in the training for the diagnostic portion of it. So we've been going through the HODS program, and that's been great. Their educational portion of it is top notch. The really cool part for us is, for example, patients that go see their family doctor with rotator cuff pain or shoulder pain in general. So we're also doing musculoskeletal ultrasound. So there's 20, I think the literature is 26% of all patients that go to a family practice for shoulder pain have some sort of rotator cuff lesion. So for us to find that out on day 1 putting the musculoskeletal ultrasound on that patient, like how bad is this? Like, do you have a tear that's 50%? Do you have just a small tear? Do you have just tendinopathy, or do you have like almost a full thickness tear? And then for us to be able to make appropriate referrals out to surgeons has been golden for our practice. Like, it really increases the level of trust, not only from the patient that you send, that you found that, full thickness tear, but also the level of trust of the orthopod that you're referring to. And that's been probably the most significant aspect of it.
Great. So you're doing musculoskeletal ultrasound and EMGs.
Yep.
Correct. Right. Very cool. And then, so private practice questions for you. 13-ish years in right now. Yeah. So what are, when you think about your transition from, the manager and the work hardening with your, I believe you said kinesiology background, right?
Yep.
And, going through the DPT program and then coming out and being a practice owner, what were some of the challenges that you anticipated? And then what did you really face once you were out? So go back to 2005, you had a vision of what you were going to do, right? And then you earned your DPT, and then what were the real challenges there?
I mean, I was kind of like pie in the sky at that point. Like, I had gone through, I consider myself super lucky, and I don't say this because I'm on your podcast, but like, we had some really good training overall. Like, I say this often, like, basically for me, my career direction was pretty easy. I essentially copied all your paperwork and everything that you had developed, your systems, and took it and replicated it in Quarryville. So that part wasn't that difficult for me. And when we first started out, there were some bumps in the road, certainly. Now it's just a completely different landscape. We have so many compliance issues, so many insurance issues. We're trying to change physical therapy and elevate physical therapy, but man, we have such a wide variety of treatments that physical therapists provide, I think, in private practice. So I don't know that necessarily affects us, but just talking about our practice and private practice in a whole, I think sometimes that can be detrimental. Patients are unsure sometimes, I think, what they're going to get at different times, depending on what clinic they're in.
Very fair. Just thought of this. I don't believe on this podcast we've mentioned flipping the pyramid, but I never went through and actually explained what it was. Since you mentioned it, would you mind going through and explaining what it means to you, how you think about doing that?
Yeah. So flipping the pyramid to me is, we have about 3.5% utilization in the United States for physical therapy. We're all vying for 3.7 million or $1 trillion of healthcare money, but that is not the most important thing. I think physical therapists in general, want respect. They want a higher seat in the hierarchy of everything. So what's happening now is all these patients are being sent to the hospitals. They choose pharmaceuticals, and essentially what happens is that's the first choice. That's where patients go when they have musculoskeletal, nerve, or joint pain. Flipping the pyramid for me is creating an increased public awareness for the need of physical therapy, to have the public drive insurance companies, congressmen, Medicare, everybody to say, hey, like, when I go to physical therapy, I get better. And this is where I want to go first. And that to me is flipping the pyramid, where we create this situation where we are the first providers. We're the ones that see those patients with musculoskeletal joint or nerve pain. We see them first. And from there, we have excellent differential diagnosis skills. We have the ability to change that patient on the very first visit. If it doesn't go the way it should go, then we're going to refer that patient out appropriately. That's my vision for it.
Love it. What's the best way for our listeners to learn more about you, contact you? You can do it. I won't give your cell phone out, but email or website, where do you want to point them to?
Yeah, I mean, I think just go to neffpt.com. Like, this is our goal, like, to help physical therapy. So whatever anybody needs, I mean, we have a whole team that is committed to this. So if I personally, I'll put you in touch with somebody that's pretty amazing and on our staff.
Great. Dan Neff, DPT, thank you very much for being on the podcast here, man. You crushed it.
Thanks, Chad. Always good spending time with you, man.
Remember to visit getbreakthrough.com to access our free resource library designed specifically for private practice growth. While you're there, make sure you register for a complimentary growth assessment to learn about potential opportunities for growth in your local market. Again, thank you for tuning into the Grow Your Practice podcast and supporting our mission to help people in pain get back to normal naturally.